Hi everyone, sorry about the snafu with the last video. I received a text and I needed to respond to it, and I thought I had paused the tape and I didn't, and so apologize for that because that wasn't where I necessarily wanted to break. But let's talk real quickly about special examinations. In the back there's a test called the Adams Forward Bend Position, and this allows for evaluation of structural scoliosis. So you'll have the child bend forward at the waist to a 90-degree angle at the back with straight legs, ankles together, and arms hanging down freely by the sides, but not far enough to touch the floor. And you're looking at the back for symmetry or asymmetry of the height of the curves on both sides, or if there is a rib hump. It's important also to be sure to look at the back from the back as well as the sides. Sitting, getting a eye view level will give you the best visualization of the spine. And if a rib hump is present, there's a device called a scoliometer that can measure the angle of tilt. Your office may not have it. It's not that significant something to have. A spinal rotation of greater than 5 to 7 degrees indicates the need for further evaluation. Next, let's talk a little bit about diagnostic studies that can be done for the musculoskeletal system. These will include radiographs, an AP and lateral chest view, and a comparison of both extremities. You can also do CTs. They're going to give more detail, especially if you're looking for a concern for a soft tissue lesion. And then they're also going to give a relationship of the bones to other structures that attach to the bones. MRIs will be used for to assess joints, soft tissues, cartilages, and medullary bones. And then ultrasounds can be used to assess cartilage tissues and effusions of hip joints. Other tests may include bone scans, and they're more sensitive than x-rays, and abnormal uptake is what you're trying to assess, especially if you've got obscure skeletal pain. It's important to be cognizant of levels of radiation when doing CTs and x-rays. Labs that you may want to do if you're trying to identify a systemic disease would be to rule out infection and inflammation. You might be doing a SED rate, a CRP, CBC with a diff, blood cultures, rheumatoid factors, and an ANA. If you're more concerned about muscle metabolism, you may check a carnitine, lactic acid, leptin, and pyruvates. And then, if necessary, you could order biopsies of bone or muscle. When there's musculoskeletal issues, there's several things that you may be counseling parents and family about. It's important that they have knowledge on the pathology of the condition and any possible etiologies. They are going to want to know about the treatment plan and the prognosis, any genetic implications, and if there's going to be the need for long-term care. There are several things that you can do to help parents. They may feel that their child is behind on a musculoskeletal development, and you can do a lot to help with anticipatory guidance. First off, you have to understand and know as much as you can about musculoskeletal development, but then give the child's family a description of the child's predicted musculoskeletal development, where you feel that they should be at the time. Timelines and markers that parents can use to monitor the development are very helpful in families understanding certain patterns of growth. If there's any misperceptions, it's important to clarify those. And then families should always be given the opportunity to return for further assessment or evaluation and to discuss concerns if they still remain. Common concerns that may be seen include flat-footedness in infants and toddlers, bowed legs in toddlers, and then knock knees in preschool kids. So there are some things that can be done from a management perspective of musculoskeletal issues. The first thing we're going to talk about are shoes. This can be a controversial topic, as if can therapeutic shoes have any benefit. Studies show that the therapeutic shoes do little to correct deformities. All shoes for kids should be chosen to protect the foot from injury and to keep the feet warm. They should be selected based on their fit and to allow room for growth. So features of a good shoe would include flexible soles that allow good motion as the child is learning to that process of walking. Flat shoes, no high heels. It should be foot shaped and not have pointed toes. Fit generously, allow for growth. It should be able to provide friction in the soles that can be similar to that of the skin and not be slippery, and it should be well cushioned if being used for athletic purposes. So you may be participating in management of children that are in cast or splints. We know that these devices are used to immobilize an injury. They promote healing, maintain alignment, and they can diminish pain and protect an injury. It's important that these devices be kept cool, clean, and dry. Bathing can be an issue, so wrapping it in a plastic wrap or a bag when the child is bathing, or if there's concerns that the cast may get wet. If something does get wet, a hairdryer on a cool setting can be used to dry small areas. And if it's soiled, it can be cleaned with a damp washcloth and a cleanser. It's important to teach parents about a circulatory assessment to check on the function of nerves and blood vessels. We have all, if you've ever had a cast or know someone that has had a cast, know that it can be itchy. So it's important to teach the children not to put anything into the cast, such as toys or thin objects, possibly to itch the area. These may impede blood flow or cause neurological issues. And you may be helping coordinate physical and occupational therapy. Children with developmental delays, cerebral palsy, spinal disorders may benefit from physical or occupational therapy. The focus of these treatments is to improve gross and fine motor skills, to help with balance and coordination, to increase strength and endurance, and then to also help with cognitive and sensory processing. Let's next talk a little bit about orthopedic problems specific to children. First, we're going to talk about some arm issues, and the first we'll talk about is an annular ligament displacement. This is a subluxation of the radial head and is often called a nursemaid's elbow, as it is a frequent injury in kids from 6 months to 5 years old. It typically occurs when traction is applied to the arm of a young child, and it often occurs when a young child is being pulled by the hand or by grasping the child's hand to prevent a fall. This motion causes the annular ligament to slide over the head of the radius, and then it becomes entrapped. When assessing this, it's really important to assess your history. Has there been nonspecific symptoms, such as the child crying? Was there immediate pain or limited supination of the area? The child typically won't flex or extend the elbow, and they may hold their arm against the body tightly flexed. Diagnosis is usually made by clinical symptoms, as x-rays are usually normal. If the history of the injury is not consistent with what is expected, the mechanism expected for a nursemaid's elbow, if the physical exam leads to the concerns that there's further injury, then doing x-rays is indicated. So with your differential diagnosis, after you attempt to reduce it, if that's not effective for the pain, then you need to consider a fracture. So management of this displacement, there's two techniques that can be used to reduce the radial head. That can be supination and flexion, or pronation. I won't go into the details of this specifically, but you can read more about that in the book. With this reduction, if you hear a palpable or audible pop or click, it usually indicates there's been successful reduction. But if there is epitrochlear tenderness, then reduction should not be attempted, as this may indicate a more serious injury. Some complications would be if you're unable to reduce successfully, then it needs to be immobilized and referred. Recurrences can occur with this type of displacement, and it's important for parents not to lift their child by the hand or the elbow. Next, let's talk about brachial plexus injuries. We know that the brachial plexus is a network of nerves in the shoulder that originates in the spinal column that enables movement and sensation in the shoulder, the arms, and the hands. Injuries that occur in this area during birthing process may be known as an obstetrical brachial plexus palsy or a neonatal brachial plexus palsy. And these are the ones that we're going to talk about in this section. The injuries can be classified using the NURS criteria and range from type 1 through type 4. Most injuries impact the upper brachial plexus, the C5 and C6, resulting in weakness and paralysis of the shoulders and upper arms, and this is known as the Erb-Duchenne palsy. And then more severe injuries involving the lower plexus, C7, C8, and T1, impair hand function and can cause ipsilateral ptosis and meiosis, and this is known as Dejerine-Klumpke palsy. When assessing these, it's important to know as much as you can about the obstetrical history, as how the child presented at birth can impact it, and also if the child was a macrosomic infant, they can be at increased risk for brachial plexus injury. There are several maternal factors that could lead to this, such as diabetes, obesity, maternal age greater than 35, and the maternal pelvic anatomy. On physical exam, you're going to do a thorough head-to-toe exam to identify any deformities or any other issues. It's important to assess passive range of motion and newborn reflexes. In your Erb's palsy, you may notice an adducted arm internally rotated. There can be some absent bicept reflexes. You may notice a limp wrist or hand, the absence of a grasp reflex. You may notice Horner syndrome, which is an ipsilateral ptosis or meiosis. And occasionally there can be hand paralysis with a normal shoulder. You may also note that there's ruptured intra-abdominal structures, which could be related to delivery, and this may be seen in the liver or spleen. There may be limited neck movement, possible skull fractures, and there may be impaired respiratory effort. Diagnostic studies may include x-rays, electrophysiological studies, MRIs, and then you also want to do a chest x-ray to rule out if there's been any phrenic nerve injury. Differential diagnoses will include an epiphyseal separation of the humeral head, fracture of the clavicle or the humerus, and possibly septic arthritis or acute osteomyelitis. Management is going to be multidisciplinary with referral to health professionals who specialize in treating brachial plexus injuries. This referral should take place in the first week of life. And the initial goal of therapy is to maintain passive range of motion, maintain supple joints and muscle strength. Complications can include internal rotation contractures and hypoplasia of the arm, and prognosis recovery may occur spontaneously, but more severe situations require surgery, which may require complete recovery in years. So clavicle fractures are seen in newborns as a result of the birth trauma, and also in young children as a result of accidental or non-accidental trauma. They can occur as a result of a direct hit or an indirect trauma, and mostly are associated with falls. The clavicle is one of the first bones to ossify and the last physis in the body to close, and this usually doesn't happen until 25 to 30 years old, the book says. So our history is important to assess for difficult delivery. Was there a high birth weight? Is there irritability when the shoulder and the clavicle area is moved or lifted? On physical exam, you're going to be looking for pain with shoulder movement, any decreased arm movements, if there's asymmetrical arm movements, any swelling, any bony abnormality, crepitus, if you can palpate a callus, if you see any spasms of the sternocleidomastoid muscle, and if there's been any issues with Erb's palsy. You would x-ray the clavicle to assess for a fracture. You also need to include brachial palsy and shoulder dislocation in your differential diagnosis. If for the management for a neonate, there's no treatment or immunization depending on the pain level. Sometimes you may see that an infant's sleeve is pinned to their shirt to decrease mobility. In children, they may wear a sling immunization immobilization for comfort. You may see a figure 8 brace. Of course, you want to provide analgesics as needed. Surgery is not common, and prognosis is excellent. Moving past arms, there are some rib issues that you may see, costochondritis or sternochondritis. And this is a common cause of chest pain in children and adolescents, not a cardiac chest pain, but a musculoskeletal chest pain. And what it is inflammation of one or more costochondrial cartilages, and you can have localized pain in the anterior chest wall. Characteristics of the pain may include an acute or a gradual onset, sharp, dull, or a darting quality to the pain. It may radiate from the chest to the upper abdomen or back. There can be complaints of tightness caused by a muscle spasm, and then some exacerbating factors will include coughing, sneezing, a deep inspiration, movement of the upper chest and upper extremities. Physical exam is going to show tenderness over the costochondrial junction. You may see the Tietz syndrome, which is pain, swelling, or redness or tenderness at a costochondrial junction. If it's been caused by trauma, ecchymosis may be seen. Diagnostic studies are not indicated. Differential diagnosis may include rib fractures, and management includes mild analgesics, NSAIDs, and cough suppressants if cough is an issue. Next, let's talk a little bit about back pain. Most episodes are brief and non-specific. Most kids do not commonly complain of severe back pain. Back pain that would warrant immediate attention includes those of younger children than 4 and those with persistent symptoms. If there's limited activity, if there's increasing discomfort, nighttime pain, if there's been any systemic or neurological symptoms, if there's a history of TB or cancer, that would warrant immediate attention. When you're conducting your history, you're wanting to know as much as you can about the onset, duration, location, frequency, intensity of the pain. It's important to differentiate between mechanical and inflammatory causes. The history should include questions that relate to the timing of the back pain, as well as aggravating or relieving symptoms. Specifically, you want to know if the back pain is reported with morning stiffness or prolonged rest is associated. Then it may be leading you down the path of inflammatory causes, whereas back pain reported with activity is associated with more mechanical causes. In older kids, you also need to assess their involvement in sports, wearing high heels, and then computer use. Physical exams should include a complete musculoskeletal and neurological assessment with the child exposed enough for a good clinical exam. You need to inspect for any changes in the alignment of the back, any issues with range of motion during flexion, extension, and lateral bending. Palpation is important to reveal any areas of tenderness or a muscle spasm. And then also you want to palpate the top of the iliac crest to assess for leg lengths. And then also including a careful neurological exam. Diagnostic studies may include a CBC, a SED rate, a CRP to assess for infection. You want to do a rheumatoid factor and an ANA if you're concerned from a rheumatological component. You could do AP and lateral x-rays, and then also MRI or CTs if neurological symptoms or bone involvement is suspected. Differential diagnoses. Occult pathological conditions need to be ruled out. Discitis, vertebral osteomyelitis, fracture, and tumors can cause significant pain in little ones. Management is going to be determined by the cause, and if the pain is related to an injury, pain management and physical therapy may be part of the treatment plan. Let's talk a little bit about scoliosis. This is a 3-dimensional deformity, most commonly described as a lateral curvature of the spine. There are 2 types, non-structural and structural. Non-structural is functional. It's a curve without rotation of the vertebrae, and it is reversible. It's caused by posture, pain, and leg length discrepancy. Structural is a rotational element of the spine. Diagnosis is made on the degree of the curvature using the Cobb method, and this is determined by a radiologist. There can be three different types. Idiopathic, where the etiology is unknown and is likely multifactorial, and it's the most common type of scoliosis. These can be further divided into three types classified by age. Infantile is 0 to 3, juvenile is 3 to 10, and adolescence is 11 and older. Congenital is a structural anomaly present at birth, and it's often associated with other congenital abnormalities such as kidneys and cardiac. These curves can worsen quickly during periods of rapid growth. Neuromuscular is the most common in non-ambulatory patients, and it's secondary to weakness, imbalance, and spasticity of the muscles of the trunk. So idiopathic is the most common type of scoliosis. Its etiology is unknown, of course, but it often has a familial or a genetic pattern. Hormonal changes can play a role in how the disease progresses, and a rapid growth spurt is believed to be a significant factor in the progression of the curvature of the spine. The incidence is equal for both boys and girls, but girls have a much higher risk of developing a curve greater than 30 degrees. On your physical exam, it's important to do this while standing, while the patient is standing, and you're looking from the side and the front to note asymmetry. You're noting shoulder height, scapular prominence and height, waist angles, rib prominence, overall chest symmetry. You're trying to determine elbow to flank distance, rib heights in a forward bending position, leg lengths, and you're also looking for any hairy patches, nevi, cafe au lait spots, and dimples. Diagnostic studies to help evaluate this may include a standing AP and lateral spine. Your differential diagnosis is ruling out structural versus functional, and if there's any systemic problems. And then management includes stopping the curvature progression, and if there's involvement in the pulmonary system, improving that function. Management include observation, bracing, or surgery, and referral to appropriate specialties is essential. Next, let's talk a little bit about kyphosis, which is an exaggerated curvature of the thoracic spine. With this condition, there is an AP forward curvature with the apex posterior, meaning the upper back is more prominent. The spinal column points backward, and when viewed from the side gives the appearance of being a humpback position. The cause and the severity of the kyphosis will lead you to your different treatment options. Postural kyphosis may improve with exercise and physical therapy to strengthen the supporting muscles. Activities such as dancing or swimming that require full range of motion of the shoulders, backs, and arms can be helpful. It can also be treated with back brace exercise and PT. Surgery may be required in children with structural problems that cause the kyphosis, and in adolescents with a curve of the back that exceeds 50 to 60 degrees. Let's finish off the back with lumbar lordosis, and then we'll stop part 2. So, lumbar lordosis or hyperlordosis is an AB curvature of the lumbar spine, and this is when you'll notice when the child stands that the abdomen and the buttocks protrude. It's the least common and is often associated with kyphosis or scoliosis. Congenital lordosis is usually progressive, and it can also be as a secondary result of a hip problem in which full extension is limited by the hip flexion contractures. So as a provider, if you suspect lumbar lordosis, it's important to have the child bend forward. If the lumbar spine flattens and the lordosis disappears in the forward bending position, it indicates that the spine is flexible and that lordosis is only physiological. It's important to follow up with these kids in 6 to 12 months, and exams should be repeated to ensure that things are not progressing. If the lordosis persists in the forward bending position, this indicates a fixed structural deformity and the child needs a referral to an orthopedist. We're going to close out this part 2, and we will come back to talk about hip issues. Thank you.